Good afternoon. Thanks for joining us. I know it's been a good, long day and given us a lot to think about. I'm Ryan. I'm the Chief Strategy Officer and General Counsel at Partnership for a Healthier America. And for those who are not familiar with us at PHA, PHA is a nonprofit. It's located just a few blocks from here on Pennsylvania Avenue with a mission to solve the childhood obesity crisis by making the healthy choice the easy choice in all communities. And we do that with a lot of influential folks. We're fortunate to work with our honorary chair, First Lady Michelle Obama, with experts in the field like Bill Dietz, who I see back there, who's newly installed as the director of the Sumner Redstone Center at the Milken Institute School of Public Health. And just this past year, we were really fortunate to enlist the help of about 55 different celebrities in our work. But I think most importantly is that we spend our days working with top executives at top companies, negotiating what we believe are meaningful commitments that will help move the dial on obesity. And as we've heard in several sessions earlier today, we're in the midst of a public health crisis. We have about 1 in 3 children in this country that are overweight or have obesity. We're estimated to have half of our adult population with obesity by 2030. It's staggering. And I know in one of the earlier sessions that I was in today, we heard a lot about the incredibly high prevalence of preventable chronic diseases. And Mike Milken shared with us what I thought was a really staggering statistic in our opening session, that the failure to address chronic diseases costs the U.S. economy more than $1 trillion annually. So for this panel, we're going to talk about solutions. I think we've heard a lot about the issue earlier today. So we're going to talk about solutions, and we're going to talk about one part of the puzzle, which is employers and what we can do to have a healthier workplace and a healthier workforce. We have what I believe to be the perfect panel to talk about this. Employee wellness plans, as we all know, likely in this room, are a hot trend right now. Some, frankly, have a little more style than substance, and some have had a real impact. And so I'm going to introduce our panelists, and we're going to hear about what makes the difference between those with style and those with substance. First, here to my right, John Agwunobi, Chief Health and Nutrition Officer at Herbalife. He's also the former Assistant Secretary of Health for the U.S. Department of Health and Human Services and former President of Health and Wellness at Walmart. To his right, Professor of Health Policy at the Milken Institute School of Public Health, Jeff Levi. To my left here is Steve Burd, founder and CEO of Burd Health and former chairman and CEO of Safeway. And to his left, Mark Wagar, president of Heritage Medical Systems and the former president and CEO of Empire Blue Cross Blue Shield. I'm going to start with Steve, because Steve, you have a really interesting story to tell from your days at Safeway. And I'm hoping you can just share, I know there's long versions and short versions of the story, but if you could share with us the short version of what you did with your employee wellness plan at Safeway.
Sure, I'll give you what I call my elevator speech.
Perfect.
But we'll start on the 40th floor.
Okay.
So we have a ways to go. So a supermarket business, historically known as a low-margin business. I got into employee wellness because I had a $1 billion healthcare bill in 2005 growing at $100 million a year. One of the first discoveries for us wasn't a discovery for the medical profession, was that about 70% of healthcare costs were really driven by behaviors. And so as a business guy, I thought that was terrific because as a self-insured employer, I could design a healthcare plan that would encourage people to have a healthier lifestyle. Shortly after that, we discovered that 74% of healthcare expenses are confined to 4 chronic conditions: cardiovascular disease, cancer, obesity, and diabetes. So we put together a biometric screening program, and from the get-go, that became an outcome-based reward system. And I think today, Ryan, something like 25 to 30% of companies in the United States do biometric screening. But I only know of 2 in the United States that have a genuine, absolute outcome-based system, and I actually installed both of them. I'm sure there are more, but they haven't come to my attention. So what does that mean? We started measuring obesity, cholesterol and triglycerides, elevated glucose levels, separating type 2s and type 1s, because we had different objectives for the two. And then we measured smoking, and we had enormous success. I'll just show you one slide. I think it is slide 5, is it? Let's go with slide 4. I'm sorry, slide 4. It'll help speed this along. And okay, we get a truncated version. So what you can see in blood pressure, 58% of our people originally passed that standard, the national standard. By 2010, actually most of this was done by 2007. In about 2 years' time, 89% of our people passed that standard. When I left the company in 2013, 89 still passed that standard. This is a common cohorts over really a multi-year period. Those on the HbA1c, again, for diagnosed diabetics, Dave, I think you'll appreciate this. We established 7.0. You know, we'd like to get them in the 6.5 or below range, but 7.0 is a good number for type 1 diabetics. And then type 2 diabetics, we'd like to have them, kind of in the 6.0 range if we could do that. And what happened is that we went from 75% of them in meeting those standards to 86. BMI, which you're focused on, obesity, you're focused on it with children, but we had a 28% obesity rate in our company, and I think that was much lower than the nation. And I think Walmart would be the same, John, because people are on their feet all day working, burning calories. My goal was to be the lowest obesity state in the United States. We had 300,000 lives under our plan here. And when I left in 2013, we had a 21% obesity rate in the company. And for those that had gone from over 30 BMI to under 30 BMI, about 70% of those continued to be below 30, even at the time that I left the company. The other thing you should understand is that we made this plan 100% voluntary. So you weren't required to be measured. 85% of our workforce said, I want into that plan. Now, why did they raise their hand? Because it became the path to the lowest cost premium for them. So we rewarded them with a reduction in premium. Those premium rewards started in the $500 range. By the time I left Safeway, believe it or not, that was up to $2,000. 70% of spouses were in the plan as well. And in 2014 and 15, largely because of a healthier workforce, Safeway's per capita cost dropped 9% in each of those 2 years. So we think we've been able to demonstrate that. One more slide I want to show you, which is actually slide 5, as I've gotten to know the rest of the market. Slide 7, I'm sorry. So if you want to compare an outcome-based reward program to a participation-based, this is a large employer. It's been doing this for more than 5 years. They have a 47% of their population meeting the national standard on blood pressure, 52% on glucose compared to the Safeway numbers, BMI about 68%. And really, as I looked at this over the last 2 or 3 years, virtually no movement. I think the secret here is accountability. And I'll give you just one example, and then if I have nothing else to say, that's fine. Imagine that if we had something like a Fitbit that you wore when you got into your automobile, beginning at age 16, and it recorded how many times you broke the speed limit, how far you were over the speed limit, whether or not you were stopped by a police officer for violating a traffic law, fender benders, totaling the car, all that stuff. It just appeared on your personal dashboard, didn't go to your insurance company. How much driving behavior change do you think you would get? I know in my son's case, I would get none. And he had a bad driving record. As soon as he started paying the premiums, suddenly his driving record got very good.
Well, I'm going to go to Mark next. Mark, Steve presents a really compelling case for a robust employee wellness program. And I think even for those corporate executives not compelled by the health outcomes, the cost savings are compelling. From your vantage point, both at Heritage and your previous experience with the Blues, does investing in prevention in this way save a company money in the long run?
It absolutely does. A good example in Heritage, and we take care of about 1 million patients in 3 different states. The biggest chunk is in California. Others are New York and Arizona. And it's a physician organization, so we are the entity that is supposed to be caring for and taking that responsibility. But we extend through not just physicians we employ, but independent practices. There's about 30,000 physicians involved, but all kinds of other practitioners as well. And bottom line, and this is one of the things that I think public health schools, if we're talking to the deans or if any are here, you need to boom about this, because we're at the far end of the scale. So all this value-based care people are talking about, all million patients are paid on some kind of performance basis. For 800,000, we take the majority of the premium from multiple payers, the government, private insurers, and we manage it on behalf of their customers. And where we're able to execute on health and wellness, as well as what we call the mud wrestling, which is getting in there and trying to work with physicians and hospitals on the things that they could do better. That'll get you 10 or 15, 20%, but you might have to spend most of that to get there because it is mud wrestling. The real opportunity is the 74% that the Milken Institute talks about that is spent on things we do to ourselves. And that's what we become obsessed with because it's our money. It's kind of like your money at Safeway. So this is our money. And the example that rings home with a lot of people, we all have older family members. We might take care of 50,000 seniors in 2 counties. 5,000 might have congestive heart failure. But if we're the traditional physician office, we'll build a nice office and we'll have the right specialists available, everything else, for when you fall in the door so sick or injured that you present yourself or somebody hauls you in a vehicle. What about the other 4,000? When you're paid differently, or when you think like the Safeway that was paying the bill, all of a sudden 30,000 doctors are thinking like Safeway and saying, well, the other 4,000 are going to fall in the door at some point. What if I knew everything about all 5,000? What if I knew where they lived, what their aunt's name was, whether they live with their kids, whether they're in an urban setting on a 4th floor walk-up or a rural setting? Did they just have a fight at Thanksgiving with their 92-year-old brother and they're depressed and won't come into the office? What if nobody's at home to take care of the cat for 2 hours, and that's why you haven't seen mom in 2 years in the office and she refuses to come? And you basically just have to break down the barriers, and with all due respect to benefit plans, and I was guilty of that, we can make them so complex. We ignore, for the most part, whether it's workers' comp or medical or anything else. We think those divisions are all artificial because all of the causes of why people present are interlocking. So the person who's depressed, and whether that came first and the obesity came later, or the obesity caused the depression, is going to end up getting hurt, moving pallets around in the back room at a Safeway store. It's all related. And anybody tried to sign up a relative lately for Medicare? I did that recently. 5 different signups. So you got Medicare, you got Part D, then you go for a supplement. This is assuming you don't sign up for a Medicare Advantage where it's packaged yet. Then you got to go for a supplement. Then in order to get the wellness benefits, you got to have yet another piece of the lifestyle pieces, and then there was some other crazy thing.
Well, you need IBM Watson to actually figure it out.
Exactly. And my point about this is we are artificially, we made mistakes years ago breaking up all these things. All of a sudden the rage is combined behavioral health with medical. Well, duh. Are they related? Are people with severe mental health problems, do they have more medical problems? Do people with more medical problems end up having more behavioral problems? It's all tied together, but public health is too quiet. The kinds of things that they did at Safeway are exactly what we try to do in our medical group. So we will send out whoever it takes 24/7. If there's a cousin you'll talk to, if there's a college kid on the block that will come by and see whether you've got throw rugs all over and you've fallen 3 times in the apartment already, and the 4th time is going to be when you break your hip. Those kinds of interventions don't have billable events. And I think how you finance the system and how you pay, sometimes you get what you pay for. In California, where our biggest concentrations are, we're the only medical group that is a 5-star plan, if you know about the plans other than Kaiser. And we do it with both employed and independent physicians. So it's, completely on board. If you want to cut utilization and costs in half, do the full package, don't do piecemeal.
Thanks. So, Jeff, Mark says public health's being too quiet. You represent public health on the on
So
this
does
panel.
John.
We all do.
I mean, we all do. But you ready to boom about it? As Mark said, is our employee wellness plans what we've been waiting for? Is this the solution?
So I'm not sure that what Mark described was an employee wellness plan. It was a very different approach for how we address the needs of a population, whether it's an attributed population that's part of an insurance plan or in a community. And there, I think public health has been quite vocal and quite creative. There's been, ever since the passage of the ACA, a whole dialogue going on between the public health world and the healthcare world around thinking about the whole person and all the needs that an individual has, and whether or not those services are directly healthcare services, or it might be social support services or other types of services that are needed. So just recently, the Center for Medicare and Medicaid Innovation put out a funding opportunity announcement for accountable health communities, which is specifically trying to address the fact that people with healthcare needs also have social services needs. And if you're not addressing those social services needs at the same time, you're less likely to be successful in achieving good health outcomes or lowering costs. So I think that's different from a workplace wellness program, and that is closer to, I think, what Mark was describing, is de-siloing all the funding streams that are available either to individuals or to providers to assure the well-being of an individual or, for that matter, a community. I think, the jury is still out to some degree on workplace wellness programs as to whether, there's a huge debate going on in the health policy blogosphere as to whether we have enough evidence to know whether these work or not. I think there's some real questions about fidelity to high standards, and I think Steve would probably agree with that, in the implementation of workplace wellness programs. And until we have some consensus about what that means, it may be very hard to really know whether, done right, workplace wellness programs make a big difference, or in some cases, if it's not done well, are we actually adequately spending our resources? There is certainly a role for health promotion. I think anyone in public health would agree that there's a role for health promotion in the workplace, because that's where you're spending almost a third of your time. How it gets tied back to how people live in the community, I think, is another story. I think where there is some disagreement is and part of it is philosophical, and part of it is also just practical, about whether these should be coercive programs or not. When you're charging someone, if non-participation results in your paying $2,000 more in your health insurance premium, that's no longer voluntary. That's coercive. And it may be legal, and it may be one of those exceptions to medical underwriting that was permitted in the Affordable Care Act. But philosophically, I think it goes against the grain of what health reform was about, which is that having insurance shouldn't be based on your health condition and shouldn't be predicated on whether you engage in certain programs or certain behaviors. And so that, I think, is a philosophical difference. Whether they work, I think some do and some don't, and I think we need a better sense of what the quality standards are.
Obviously you're going to go to John, but clearly I get a chance to respond.
Yeah, like in every political debate, your name was mentioned, and so
Yeah,
fair
exactly.
time.
you get to respond.
Even if it sounds like your name was mentioned,
Okay, yes.
No, go ahead. Go to John first. I'll remember.
I was just going to comment on the fact that Jeff mentioned this notion that employee wellness programs are, I think a good way to describe it might be emerging practice. And like in most areas of practice, whether it be medical, public health, or whatever, science tends to follow a kind of innovation. And I do applaud Steve and his work at Safeway. It not only influenced how Safeway has conducted itself going forward, but I would say it also kind of eased itself into the Accountable Care Act. I know for a fact at Walmart it was the basis for what we did there. I happen to know that the programs, I'm brand new to Herbalife, so I can't speak with much authority, but I know this. Their wellness program was modeled very closely on the program that Steve innovated in Safeway. The bottom line is, for us to get to a place of robust science, we have to start with people willing to innovate. We have to have a culture, an environment that is willing to embrace and engage innovators and help promote the notion of new ideas and tests on our journey towards solid science. You know, with that in mind, I'll point to something else that exists today at Herbalife, which I've found powerful because it relates to a personal passion that I've had all the way back to my days of public health in Florida. And that is this notion that the workplace as a silo could offer more. It could actually engage its workers and have those workers join public health in basic dissemination and promotion of messaging into communities. It could also, you know, people bring things home from school. Kids in the tobacco fight, as you know, all of us, I think, in public health recognize that the work that we did with children resulted in gains in the home. It has across a number of different efforts. But I also think work that we do in the workplace can lend itself to being taken back out into the broader community. An example would be the 4 million independent contractors that work in Herbalife. They are essentially, each and every one of them, an independent contractor, a passionate advocate for wellness. Now, it has to be better defined. There's a need for better science and codifying what their messaging and what their work looks like in communities. Today, it's a little all over the place. But in essence, they're fighting for fitness, they're fighting for healthy nutrition, even as they build their little businesses, each and every one of these 4 million people around the world. And the point that I'm trying to make is, imagine if we could harness every single one of Steve's former employees at Safeway, the 2 million employees at Walmart, the 4 million independent contractors at Herbalife, and all of the others that have kind of interacted with health and public health in a more formal way in the workplace, and engage them with a challenge and incent them to go back out into their communities and change the world. That's the challenge that I've always kind of found exciting, and that's why I'm on the corporate side now.
Well, John, and we'll come to you in just a minute, Steve, but
I hope so.
I do promise. I do think it's interesting to draw the distinction that you just drew with Herbalife, and your workforce is largely an independent workforce. So what's motivating you is not saving healthcare costs, because I don't believe you are covering the healthcare costs of an independent workforce. No. So what motivates you?
Yeah, so we have two workforces. There's the 6,000 employees of Herbalife, of which I am one. And that's the group that I was mentioning has been offered, in addition to their health benefits and insurance plan, they've also been offered a wellness program modeled very closely on the one that Steve described. We don't have quite the same number of outcomes. BMI is one, smoking cessation is another, but beyond that, we're taking it slowly. The broader group, these independent, 4 million independent contractors, they don't work for us. They are all, each and every one of them, independent entrepreneurs. In many cases, in fact, I would say in most cases, we're not their main source of income or revenue. They work for other people, have other jobs, and in many cases, their own businesses. What we do provide each and every one is training and education on fitness and on healthy nutrition as a part of their relationship with us. And the question is how, and I think one of the reasons I've been invited to join the group is to try to figure out how might we give them public health roles and responsibilities that they take into their small communities of 10 or 6 or 7 or whatever the number might be that they talk to on a daily basis.
And from a business perspective, what would that bring back to Herbalife? If you're
Nothing.
Able to do that?
There's two things that we believe we should stand for. One, we should be a company in the future, and Michael Johnson, the CEO, is really committed to this, being a company in the future that stands for more than just the business side of the equation. That in the end, health is good business. Health in a community is great business. You have a healthier workforce. You have a workforce that is better able to kind of make decisions because less of their very tight incomes is going to one proposition, their healthcare needs. They can now make more choices with those. And this is, by the way, was true for Walmart and others. Most big companies that get into this notion of improving the health of their communities do so because they recognize without any hesitation that a healthier community is a better consumer. But beyond that, it's about the fact that you motivate workers. You're an inspired organization when you have a purpose, and that's really what we're building.
Yep.
I would have to jump in here, and just one of the things that jumps out at me is one of the problems with workplace-based wellness and benefits, and with public health, all due respect, is we're in this room, not everybody from the seminar is in it. This has been treated for decades, and public health to a degree, inappropriately for decades, as an optional add-on. When you're taking care of people cradle to grave, it is not an optional add-on. So the 10-year-old who's about to become a type 2 diabetic because of the diabetes, incidence rate increase, we needed health and wellness for them when they were 4, and for that household and for that family, whether they were on Medicaid, whether they were on a commercial plan, whether they worked for a big company or a small company. And then, you end up in midlife, you're going to be paying for the kids in the household who are now type 2 diabetics, because before they became your employees, something else wasn't happening. When they're aged, I just talked to one of the deans of the public health schools who's an internist. She says, I saw this in my practice before. This is why I went into public health. I'd see people that 20 years earlier, if something different had been done. So I think we should come out of this with unusual partnerships and collaborations. So the federal government, if they really want to control Medicare costs, should have a deep interest in what Steve or others do and what the Herbalife people do when they're out proselytizing on good health in the marketplace, and what the public health school do. As to that's an investment. You want to drive down incidence rates and severity and how long it takes for onset of ultimately we're all going to die from something. It was when you were 35. It was when you were 25. It was when you were 7. And by the way, why do we chop it up? Why is the network that takes care of your health and wellness different from the network that you have for your medical coverage? It's different when you lose your job and you're on Medicaid. It's different when you're a senior. You want to talk to a different internist every time and assume that they all look at things the same way. So I think our separation of this as an optional add-on is one of the biggest problems, and one of the reasons we aren't realizing faster change. The last thing I'll say is about change is we don't have 30 years, okay? The kind of blunt intervention one of the speakers talked about today, one of the elected officials, a congressman, said there were all these interventions by the federal government lined up with 20-30% cuts in Medicare. If we don't change in the next 10 years, which means change in 5, because you're only going to see it in the next 5, you're going to end up with blunt government intervention, which will pay for mediocrity. It will not pay for innovation, not because the government wants mediocrity, but because they can't afford it.
Right. All right, Steve.
So I want to obviously respond to something Jeff said, and I want to elaborate on something you said in your first remarks, I think, Mark. If I could just have slide 1, I'll try to make a point here. Remember, I've reduced 2 hours down to 5 minutes, so
Okay.
it's a little bit of a challenge. But, I picked 1962 because that's when I was in the 8th grade. Okay, I entered high school in 1963, and what you can see is the obesity rate among adults in this country were at 11%. And in 2015, the latest number I saw, you see any number between 36 and 38. At the high school level, there was a 5% overweight rate among students, and today that's around 30%. That's not a genetically driven result. That is a behavior-driven result. And so when we approached our wellness program at Safeway, we were very careful to build a comprehensive ecosystem so that everything worked. I reported the quarterly earnings to the public, and then I went into a town hall meeting, then I broadcast to 1,800 stores. We reported the earnings, and I reported on the wellness of the company. I did that every single quarter. I had prostate cancer in the year 2000. At that time, it was a real roll of the dice of whether or not you could end up incontinent post-surgery. I found a surgeon that had a 0.2%, 1% incontinence rate, and the average surgeon not using nerve sparing had 50%. So I found a surgeon 250% better, or 250 times. So one of the things we did in this ecosystem is I created a cancer concierge service for 185,000 people. I made one phone call to Mike and I got connected. So I said, well, I want to do something for 185,000 people. I want to give them something they can't buy. And so we had a concierge function headquartered at UCSF, which represented the hub, and they fanned out to every cancer center in the United States. And people with one phone call got a navigation, got appointments at MD Anderson, Johns Hopkins, Sloan Kettering, wherever they were in the country. And my goal was in 5 years' time, there would be an employee in every single store that believed that they or a friend of theirs or a family member was alive today because of what we did in our wellness plan. We put calorie counts in the cafeteria, we put nutrition, we stopped subsidizing cheeseburger and fries, but I'm a free market person. I believe in cheeseburger and fries, with moderation. And so we didn't subsidize those. We built a 13,000 square foot fitness center on site. We subsidized by buying down the premium for all the 24-hour fitness and all the other gyms around the country so that 185,000 people would have access. We created tools to help people improve. We were really focused on people that shot out of there at 5 o'clock, went to a soccer game, and then probably went to Burger King. And so we designed things in the workplace. We had walking meetings. One of the smartest things we did is we established social networking groups before Facebook was born. All right, and these were people that collaborated together on goals that could have been fitness goals. We didn't just push wellness, we pushed fitness. I'm 66. I knew this early on that if I wasn't in shape at the age of 50, my chances of getting in shape after that were pretty reduced. And fitness, as you get older, translates into mobility, which translates into health. And so I'm absolutely convinced this has worked. It's worked every place we put it. And the issues about, my wife is a 55-year type 1 diabetic. She has no penalty under this plan. We ask her to be at the same level that we ask other type 1s. She happens to be running a 6.0. She has fewer complications after 55 years than often type 2 diabetics after 5 because of her control. I really like being responsible for the health care of my employees because it wasn't Blue Cross or United that designed this health care plan. As a self-insured employer, and I'm sure you felt the same way at Walmart, you could design it, you could build incentives, you could build the culture, and so that's what's important here. You can really make this work if the problem with healthcare and the cost escalation is it doesn't function as a free market. You can mimic a free market. Some other session someday we'll talk about what we did in the delivery system that cut our costs by 50% over a 10-year period. And I believe you can do that in Medicare. I wanted to just comment on something that Mark said. He didn't say it, but I know exactly what he's doing. I know the founder of his company. One of the reasons Mark and Heritage can put that kind of focus and sit down and get to know people personally and what's sort of driving them on a behavioral standpoint is that 10% of any organization's plan members represent about 75% of the cost. And so what Heritage does is they focus on the high users of healthcare. Now at Burd Health, we have a similar service. We call it High Touch, I Care. But healthcare is so difficult to navigate. If you are a high user, you are really having a hard time navigating. And what Mark and Heritage can do, and I now as a third party, not as an employer can do, is I can help people stay healthy.
So Ryan, I'd like to go back to something Mark said, which is about the need to marry public health and healthcare. I think everyone in this room would probably agree because that's why we're all here. But you pointed, and what you are doing, I think, is so consistent with public health principles because what you described is not just your high flyers or the people who need the high touch because they represent the 10% who are 70% of your cost, but also recognizing those, like you talked about the 4,000 who aren't at the door yet and how we need to be doing something preventive with them. And that's certainly a public health approach to thinking about care. And you talked about over a life course that the person, if we don't do something at age 15, then we're going to have problems at 20. If we don't do something at age 20, we're going to have problems at 30. And that is exactly a public health and health promotion approach. The challenge we have is that the current system doesn't reward that kind of life course approach to thinking about health promotion. Whether it is, you should have gone with Dr. Frieden to testify on the Hill with him. Whether it is people on the Hill who only think about what is your return within a year of an investment. We gave you this money. I'm sure you had testified John, at hearings like this. Well, we gave you money a year ago, so why do we still have an obesity problem? But even in less ridiculous terms, we know that many of the things that you are probably providing your beneficiaries today may not pay off for 5 or 10 years. You're taking a long view and thinking that these folks are going to be part of your system for that period of time. Most people don't take that perspective, and the financial rewards in our system do not provide those incentives. And so if we're going to have this marriage between public health, or at least public health and healthcare, and it doesn't have to be a marriage, frankly, if healthcare embraced public health principles and went off and did a lot of it on their own, that would be great too, because we're not producing enough public health workers to do it all together. If we really embrace those principles, we would have to figure out a different way of how we finance healthcare. And I'd be curious, Mark, to hear what you think might be a different way of thinking about value-based purchasing, reimbursement, whatever you want to call it, pick a term, that could really incentivize the entire industry to think the way you are thinking.
Well, the favored way to talk about it now is move toward population-based payment. But that's essentially capitation. That became a bad word. But that's what we do. That's what Kaiser does. It gives its medical group, Kaiser, if you look at the history, it was a medical group that attached a insurance company and hospitals at one point because it helped them serve their patients. In Dr. Milken's instance, he subcontracts all of that, but the core is the physician group in the organization. So I think the freedom to have that money up front. So one of the things you see out there with accountable care organizations is all the rage was shared savings. Well, I've been in healthcare a long time with physicians, with hospitals, with payers. All that means is shared savings is playing it safe. It says to me, I can continue my fee-for-service behaviors. And if I happen to save money, I'll get a bonus maybe in about 18 months after the whole calculation is done. But I've got no skin in the game. And I also have no upfront resources. So when we pay some college kid to go door to door in some neighborhood and take a look at the 100 seniors that we've been unable to go see, there's no billable event for that, but we've got the cash. There was somebody who gave the common example that everybody knows about now where, people with congestive heart failure, when it gets hot, if they don't have an air conditioner, and they walk back from the store, they're going to have an event that's going to cost $50,000, $100,000. You put the air conditioner in, they cool off when they go home, it's no problem. We can do that, certainly, but I think that has to come with lots of expectations. You should be accountable. So we should lose you as a patient and all that revenue if we don't do a good job for you from a service and access standpoint. We should hit all of the quality and other efficiency benchmarks. And the other thing is some of the money should be saved. So when I was in the health plan business, one of the biggest problems I had is, and maybe this is not Safeway, but when I said, I could make a different kind of arrangement with these providers in this marketplace, but I need you to pay them a bunch of the money up front. Lots of the big employers say, no way. If there's any savings, we want it all because we're paying the bill. Well, it's kind of like running their business too. You got to flip it around and say, you have to free up the delivery system to spend the money to do the right things to get it to come out right at the end of the way. We actually do reduce where we've got it all going. We eliminate 50% of the demand for the high-cost things. But you have to have the money up front to do that.
Let me try to clear up what I think is a misconception. First of all, and I think, John, you should weigh in on this, I've talked to hundreds of CEOs, deep discussions, hours of discussions. I've never heard one CEO say, well, I don't know if I want to do that because I don't know if those people will be there tomorrow, okay? Particularly the Silicon Valley, which is very high turn. Mm-hmm. The way John and I looked at it, this is a loyalty builder. If you can help people with an obesity problem, if you can turn a pre-diabetic into non-pre-diabetic, if you can turn a type 2 into non-diabetic. I mean, my shareholder meetings, which were attended by employees, became a love fest the last 3 years I was there. I started to do, I'd say, well, we'll open up for questions and comments, and I'd say, you know, let's just start with the compliments. And employee after employee wanted to talk about, I also created a concierge service for cardiovascular disease, so they could get the same sort of network capability. And so I think one of the problems in the insured world, or even in the self-insured world, the relationship between, say, a United or a Blue Cross or somebody, typically is with an HR or maybe a benefits person. And they have a different view. They just don't want the phone to ring. They just want life. They don't like change. But when you're talking to a CEO, I mean, to me, this is all about loyalty. And we built extraordinary loyalty. People wanted to come work for us. You know, if you can work for Safeway and you get cancer and they take care of you, and you know, with the best institutions in the country, it doesn't get much better than that. But John, why don't you?
No, Steve, I would totally agree with you. I'd take it one step further, which is every CEO that I've ever encountered aspires to have programs like this and beyond. They don't all manage to execute and pull it off. And the difference is largely leadership, right? This notion that there's someone willing to stake their own careers, their own success, on the notion of getting others to do stuff they wouldn't do if you weren't there. The concept of leadership, kind of inspiring others. It's a bit sad of a testament that says, for many, they learn more about health and wellness at work than they do when they're at home or in their communities. But it's altogether true for many. If you think about a cashier or a cart pusher or, in Walmart's case, a senior greeter, where the only times they really hear and talk about what it might take for them to engage in their own health or in the health and prevention of disease in their own communities is when they're at work. I'm being a bit repetitive, hope that the leadership that is inspired by people like Steve and others in the workplace needs to find its way back out into the community. I used to work in public health, and at the community level, that public health worker was often seen as a community leader, but to the point that you alluded to, you touched on briefly, there just weren't enough of them to kind of touch every person and every family. And an investment in public health is as required today as it was 50 years ago. There's more that we need to do. I do hope that we can begin to inspire leaders in the workplace to take their message into the community.
So I think actually we have a lot of examples of businesses trying to exert that leadership role now in their communities. You know, one very simple example is the U.S. Chamber of Commerce Foundation has now started a program, I think, in 10 or 12 communities across the country, where they're using the Chamber of Commerce as the convener in a community to talk about how you can make the community healthier, recognizing that whatever you do in the workplace, however wonderful it may be, people spend more of their time outside the workplace. And if they return to a community where healthy food is not accessible, where it's not easy to be physically active, where the air isn't clean or there's lead in the water, that is going to undermine their investment in the workplace setting. And recognizing that they are able to bring those multi-sector coalitions together to create a healthier community and a healthier environment. I think that's a very important piece. And I think what's also important about it being the Chamber of Commerce being part of that convening is they, in most communities, represent smaller employers. And I think one of the real challenges we have right now around workplace wellness programs is that they are not accessible for small employers. Until December, I ran a small organization of 15 people. It was not purchasable. And we certainly didn't have the capacity in-house to create a workplace wellness program for 15 people. And so when you think about if we really want to have a population level effect, we have to find a way to spread and scale this kind of intervention so that where a majority of people work, which is smaller businesses, these are also available.
Interestingly, at Herbalife today, there's a concept that's kind of taking the company by surprise because it was generated by the independents. Really, we didn't design it. They brought the innovation to us, which is called nutrition clubs. It has variations, different names. It basically boils down to a person who invites a group of people over to talk about healthcare or goes to their homes. And I kind of alluded to it a little earlier, this notion of independence taking the message to the community. I have no doubt that each individual was inspired by a different source, in a different way, and they've kind of come together almost birds of a feather, seeking to have an impact on their communities. They reach out to Herbalife, they reach out to others. In the same way, though, I think when people work in an environment like that which Steve Burd put together at Safeway, there's a culture that develops. A culture that says you engage because it's the right thing to do. And my hope is that when they go back out into different job settings, the cashier who joins a small business and so forth, that there becomes a circular kind of notion, an expectation that culture is viral and it spreads. And so that eventually you'll have, I recognize the cost. I haven't answered or addressed the cost issue, which is real. But like anything, any commodity, the more you do it, hopefully the lower the cost of it becomes with time. You know, if everybody expects it, if everybody's participating, costs should fall. And I think at the beginning, there's always an expense cliff that you have to, or rather mountain that you have to climb to get to the other side.
You know, the other comment I would make is that I think you can have the greatest impact, Jeff, in a large organization, first because there are more bodies. But I know your company pretty well. If they decided to scale nationally, they would have the lowest insurance rates in the United States because they know how to do population health. But that hasn't been the objective of the company. But I've often thought, right now, Burd Health serves large self-insured employers, but we may very well become an insurance company because I think we do things a little bit differently, but we do a lot of things that are the same. And you know, Mark's got more lives under management than I do right now, whole lives. But there is an opportunity, and we're trying to create, Jeff, some turnkey products that we can deliver to small businesses because there are large businesses that operate the HR function for these very small businesses. And that's a way for us to be able to scale in companies that are relatively small.
And I'm glad you brought that up because it might be that for the small businesses, a complete robust program like you had at Safeway is just not possible. But I would like to, with the remaining few minutes we have, just run down the panel and ask a loaded question because that's always fun to do with a few minutes left, to identify what are the one or two most important aspects of an employee wellness program that, you know, John, you identified leadership as an issue. And for those, there may be corporate leaders sitting here who have not dipped their toes in the water yet. And they're reluctant to do so for some reason. But if we could just say, just try this one thing, because we think this is the most important thing, what is that? Who wants to be brave and go first?
So, since John's already said it, I can't say leadership, but a leader needs to be building a culture of health within his or her own business, but also the add I would give to that, but also in the community. Yeah. Business people have to be engaged in their communities to create that culture of health.
Yeah. You can't have unhealthy people come to work every morning, clock in and suddenly be healthy and then clock out and go back into their unhealthy settings. I would add, we're partnering up here. He kind of helped me with my message. I'm going to help him with his little, which would say, I do think we need to invite the academic side of health and public health to participate in the kind of the research, the science, the evidence-based building that we use to kind of take this to the next level. That too is costly. I recognize that. We need to find ways to figure out how we're going to support that research. But gathering a body of evidence that kind of takes what Steve's experience was at Safeway and then taking it out into small businesses, into large businesses, into cooperative pools and other approaches, and trying to show what best practices are is going to be a critical part of making this sustainable over time.
I agree with everything that's been said, so I won't replicate that. I would emphasize the need to build an ecosystem that everything fits, okay? One of the new things that we've added to our playbook is that this notion that it takes 20 or 30 years for best standards of care to permeate the delivery system, we're now building into plan design. We're picking a lot of things in the cancer area to basically, you know, something as simple as if we're going to provide your benefit plans provides chemotherapy post-breast cancer surgery, provided you have these 3 genetic tests, which will help you determine whether chemotherapy will be effective at all, and if so, which one. And by the way, your plan pays for 100% of those tests. There's no copay, and one of them costs about $4,000. Okay, so everything you can do to build this culture of health, fitness, and care for, Mike talks about this all the time. It's all about human capital. And if you don't understand human capital, you're not going to want to do what the three of us just said.
I would say the keys to a workplace program are mass personalization. So you've got to have information and develop it, deliver it in a simple enough way to everybody that they can understand how this can help them and their family. Because oftentimes it's not just about them, it's about how's this going to affect their family and everything over time. And then make it actionable for them, easy to use. Because if we just get, lower cost memberships for the people who are already going to the gym, that doesn't get there. You've got to activate them.
Thank you. Gentlemen, we are out of time, but thank you very much for the robust discussion.